Next topic is the serological testing for infectious uveitis, basic principles. It will be the talk will be given by Padmamalini Mahendradas from Narayan Netrala, Bangalore. Padma.
Thank you, sir. Very good morning to all of you. At the outset, I'd like to thank Dr. Somushila, Dr. Saumavya, and AOS team for inviting me here today to speak on serological testing in uveitis, basic principles with 5 pearls. The serological testing for infectious uveitis can be used as a diagnostic tool to diagnose various infections like bacterial, fungal, viral, and parasitic infections. The principles of testing, it detects the antibodies in the serum. The first question is, what are the methods can be used for testing, antibody testing in infectious uveitis? We have ELISA, commonly used one, that is enzyme-linked immunosorbent assay. The second one is indirect immunofluorescence assay. The third one is Western blot technique. We choose the test depending upon the disease, the sensitivity of the test, the specificity of the test, according to the availability and affordability of the patient, according to specific infection. Next, when to order the serological test in uveitis? It depends upon the stage of the disease and type of the test. The toxoplasmosis is the commonest infectious uveitis across the globe, where we diagnose, in addition to the clinical presentation, serological titer is used to diagnose. There we order both IgM and IgG antibodies. In addition to that, the IgG avidity also can be used in case of pregnancy and other uveitic entities. IgG avidity confirms it's an acute infection. It distinguishes between reactivation and a primary infection. Coming to that, IgG avidity index, if it is low, then it indicates it's a recent infection. If the values are high, then it indicates it's a chronic infection. Next, we get, most of the times, antibodies are negative due to the epiviral phenomena in case of ocular toxoplasmosis. Invariably, the IgM is negative, the IgG comes positive. Then we divide the patient is immunocompromised or immunocompetent. Suppose if it's immunocompetent, we assess the serological antibodies and IgG is detected, which is increasing. And IgG avidity high level indicates reactivation of a latent infection, or it is low or intermediate level, indicates acute infection. The next, we need to understand the disease course before ordering any test. Recently, we had a COVID pandemic, which taught us many lessons. So this is a graph which showing when we have an exposure to the organisms till we manifest the symptoms. During the time when you have an exposure, whatever the tests we do, it's going to be negative. So then during the infective phase, the PCR is going to be diagnosis. So after 1 week, you can do either, depending upon the source of infection, either the nasopharyngeal swab or bronchoalveolar lavage in a case of a COVID, it's going to be positive. So the antibodies are going to rise only after 1 week. Here you can see the IgM, which usually starts after 1 week and it disappears in 6 weeks. Whereas in IgG, it can persist more than 18 months. So when we see the patient, how many weeks of post-fever or infections we are seeing, and accordingly what we can anticipate. So we have to order that antibody testing. So ELISA-based IgM and IgG are there. If you have increased IgM, we saw clinical worsening. Reinfection, if there is more than 4-fold increase in antibody titers. Most challenging was cross-reactivity with the coronavirus with many organisms. Here we see a case example. A 49-year-old female presented with here decreased vision. She has erythema multiforme like skin lesions, multifocal retinitis with retinal hemorrhages, suggestive of a post-fever retinitis. Because it's COVID, she had multiple clinical features. These are the investigations we got it. So here, what happened is PCR was negative, but what antibodies for SARS-CoV-2 was positive, dengue is positive, chikungunya is positive. She also had increased D-dimer, another profile which goes more in favor of COVID. She was put on anticoagulant, doxycycline and steroids. When we did the follow-up, when we repeated, most of the antibodies disappeared, whereas SARS-CoV-2 alone is persist in this case. The next comes interpretation of serological testing. we need to be beware of false positive and false negative when we order the test. False positive and false negative occurs due to the cross-reactivity with antibodies against pathogens or due to variations in the antibody levels over time. In these kind of situations, the diagnosis can be confirmed with additional investigations like polymerase chain reaction or intraocular fluid antibody analysis to enhance accuracy of the diagnosis. Here we see a false positive. Here again is a patient presented with blurring of vision since 4 days. She gave history of fever, headache and vomiting, and she also gave history of contact with pet cat which is unwell, and on treatment by the veterinarian, visual acuity was decreased. Here we could see a retinitis lesions in the peripapillary region. We made the diagnosis of post-fever retinitis. When we ordered the test, brucella came positive, so we started the patient on doxycycline and steroids. However, there was persistence of the lesions. By then, we also had history of exposure with cat. Here, Bartonella also have come positive. So we were wondering what it is. But when we repeated, the brucella has disappeared. So it was false positive in this case, and the patient responded to treatment, not only the doxycycline, and then we have to put the patient on rifampicin. She continued doxycycline, rifampicin, and systemic steroids for a prolonged duration for 2 months. Subsequently, the retinitis lesion is resolved in her case. Next is a case of a false negative. Here, a 45-year male presented with decrease in vision since 3 months. Negative systemic history, whatever we probe the patient. Bilateral multifocal retinitis, suggestive of probably CMV. We did the investigations. Serology for HIV 1 and 2 came negative from our lab. We reconfirmed it. TPHA is negative. ACTAP for PCR came positive for CMV. Because we had a suspicion of CMV infection, we did the CD4 count and HIV viral load. Both came positive in this case. So then again we probed it. Then this patient had diagnosis of AIDS, took ART, then stopped. He did not want to reveal the history, and finally is in the end stage of the HIV AIDS. So finally we started the patient in addition to the anti-CMV ART and as well. So at presentation, HIV 1 and 2 were negative. His CD4 count was reduced. Viral load was significant, and CMV copies were also significant. 6 months post-treatment with ART and antiviral, his CD4 count is improved to 410 cells per microliters, and HIV 1 and 2, the repeat ELISA came positive. So, HIV 1 and 2 can be false negative in early stage of the disease, in the window period of the infection, or in the late stage of the disease and the end stage as seen in our case, or in case of a treatment with intense heart during the acute phase of the disease. So you need important to find out this false negative in HIV infected end stage AIDS. So, and also we have first generation test helps to detect HIV antibodies and also P24 by 18th day of the window period. We also can do PCR from the viral load and other immunoblot assays to confirm the serostatus. The next comes Goldman-Whitmer coefficient. If more than 4 is of diagnosis, additional PCR can be helped to make the diagnosis in case of viral and toxoplasmosis. The next comes the interpretation of serological test in an immunocompromised system. So here again, especially its most challenge comes in a case of a syphilis. We have different algorithms. We order both troponymal as well as non-troponymal tests. This is a table. If both are negative, then there is no infection. Both are positive, then the patient has the infection. If it's non-troponymal is positive, it could be false positive, whereas in case of troponymal can be reactive in a treated syphilis patient. When we have patients with HIV and syphilis, abnormal B cell behavior results in increased antibody protection. The prozone phenomena, because of which we can get false negative results. It's important to dilute the patient's serum to zone equivalence to then perform the test. To summarize, it's important to understand the disease and the stage of the disease, and accordingly we order the serological test. We need to correlate with the clinical condition, and also we have to keep in mind for the false positive and false negative when we order the test. We have to interpret according to the immune status of the patient, and sometimes if the results are not in favor or in go with the clinical conditions, we may have to combine with PCR or Goldman-Whitmer coefficient to confirm the infective uveitis. These are my acknowledgements. Thank you for your attention.